Well, hi, I'm Dr. Lawrence Robbins, and this is a continuing YouTube on clinical pearls. I try to hit the highlights, and we have an expanded version of all this in a newer book, Stuff You Should Know, for doctors, NPs, PAs, clinical pearls galore. The book is heavy on neuro and psych, but we hit office practice and medicine and evolutionary medicine, etc. So the neuro exam is complex, mostly because the cranial nerves have a whole lot going on and is extensive. Most of the neuro exam is not that difficult, but there are controversies. You'd think after 100 years or so that we would have worked out most of the kinks of the neuro exam, but there's a lot of variations in how to do it. This is part one. It'll be 3 parts. In general, most neurologists do a very brief and targeted exam because in the end, with medicine and with neurology, the history is usually 90% of where we're going. After we finish talking with somebody, if we have no idea what's going on, we may very well not find it out by our exam and labs. Now, there are exceptions to this. With neuropathy, peripheral neuropathy, for instance, the neuro exam has been shown to be more accurate than the history. But in general, we rely on the history. Now, we like to state in the chart what we did rather than what we didn't do. Neuro exam 2 through 12, cranial nerves 2 through 12 intact. Did we really check them all? And what happened to cranial nerve 1? Why is sense of smell not important? So your exam is going to differ greatly based on, is it in the ER or the ICU or your clinic, and what the complaints are. There's very many variations and subtleties to the exam. For instance, old-time neurologists would call a Babinski that doesn't go up or down neutral if the other one goes down. And we used to call it neutral or equivocal, but that's fallen by the wayside a little bit. There's many examples of that. But the neuro exam is rich in history, and you have all these eponyms. Around the turn of the century, a lot of French and Russian neurologists put their name on various signs, and I think that they're interesting anyways. It's sort of like the difference between Munchausen's and the newer factitious disorder. Factitious is good. Munchausen's, it's a little bit richer in interest. So most of this part 1 is our mental status. We have mental status and gait in part 1 here. Usually we don't ask specific mental status questions, and it's fairly obvious talking to somebody, but we, particularly in the ER, if we don't know the patient, we want to assess certain things, but it's different, the ER versus ICU versus outpatient. And having a significant other there is always incredibly helpful, or calling somebody. Are they alert or stuporous or lethargic or comatose? There's an entire spectrum, of course, with lethargy, similar to being sleepy, but the patient does not completely regain full wakefulness and attention, or they can be aroused quickly, but they lapse back off. When you lapse into stupor, it's very difficult to arouse them without a stimulus such as pain. And in coma, they're not arousable, usually even to pain, a prolonged state of unconsciousness. Attention and concentration, usually it's fairly obvious when you're taking the history, but we're usually referring to impaired attention to sounds or voice. Visual inattention also we do see with problems with fixation. Concentration can be assessed in various ways, asking somebody to name the months backwards, starting December, November, and seeing what they do with it if they're in the early states of functional dementia. If they have certain types of dementia, they'll be maybe silly and laughing when they do that, particularly frontotemporal dementia. Counting backwards from 15 or 20 back to 1 works also, but you don't usually formally test concentration in most settings. You get a good feel for it while you're talking to the person. Behavior and mood. Is their mood appropriate to the situation? Say they come in and a parent just died or a favorite pet. Are they giggling and laughing? Are they acting strange or bizarre or manic-y? Now, full-blown manic-y behavior is very easy to spot. They get diagnosed. The milder manic-y states, and most 85% of bipolar patients fit the mild end of the bipolar spectrum. We miss it a lot. It's the 15% with bipolar 1, with mania, they're diagnosed. They're in the ER, or they're flagrantly psychotic or pressured and doing manic-y things. It's the milder end. So we look for that pressured speech, and they can't concentrate, and they interrupt constantly. Is the person sad or angry, elated, flat? Orientation, you don't usually test formally. Usually the awareness of the situation goes first. So in the ICU or in the ER, they may not know why they're there. And if you ask in certain ways what brings you here, you can see if they're concrete. Well, I took the bus, or I got a ride. And that's not exactly what you were asking. Insight can be difficult to assess. People have different levels of insight naturally. Some people have almost no insight. Classically, severe personality disorders have very little insight. It's the world. If they would stop making me angry, I would stop being angry. They have no insight into themselves or their children. But you can ask certain questions. Language and judgment. Is their speech appropriate? Is it fluent? Do they comprehend? Can they name? How's repetition? Judgment. You can ask people. The classic is, what happened if you found somebody's purse with a wallet inside, or a wallet on the ground? What would you do? Or if a fire broke out in your house, what would you do? Any situation like that you can ask about. Very often we're checking visuospatial. Certain dementias, etc., hit the posterior parts of the brain first. Can they copy a simple figure, usually a couple boxes, or draw a clock and put the numbers in? And that will tell you quite a bit. I like having people write a sentence. My usual is, "Dear John, thank you for the flowers." You can see if they have micrographia, if they have tremor. You can do the Archimedes spiral. Motor apraxia is the usual apraxia. Now, apraxia is a previously known motor, speech, etc., that known entity that they can do that they've lost. So, can they drink out of a cup? Can they fold a piece of paper? Can they pretend to salute? Things like that. Calculations. Can they add very simple numbers? Can they subtract or multiply? In the ER, sometimes you might ask somebody to do a more complex test. Put your left hand on your right ear, for instance. Delusions are fixed beliefs that people will not sway from, and you see that certainly in psychotic disorders. You can assess if they're paranoid. Do they have compulsions going on? Delusions happen frequently in early Lewy body disease and Parkinson's dementia. Do they have visual hallucinations where they actually see an object that's not there, usually a small person or an animal in Lewy body or Parkinson's or with L-DOPA, versus an illusion where it's a play off of something that's there. So they'll see trails when somebody moves their hand, or they'll see the stars moving around in the sky, but it's actually something that's there. If you ask in the ER about concreteness, more of a psychiatric exam. We're looking for their thinking pattern. You can ask your typical, what does this mean to you? People in glass houses shouldn't throw stones. And if they say, well, it's going to break the glass, that's pretty concrete. Or the grass is always greener on the other side is a good one. Derealization, depersonalization is interesting. It's really usually viewing yourself as if you're outside your body, like in a movie. And some people are psychotic with this. Usually they're not. It can go along with anxiety or bipolar. Often there's trauma early in childhood, but not always. Many people don't have trauma, and it can be part of a seizure as an aura with a temporal lobe or focal impaired seizure. It could be part, rarely, of a migraine aura. We're looking for flight of ideas, loose associations. These are usually obvious with psychosis and schizophrenia. Memory, we don't usually do formal testing. MoCA is probably the number one. The mini mental status is 30 points. It's a little bit more cumbersome. It was developed more in the hospital in the 70s. It's not my favorite, but it's not bad. And the St. Louis slums is pretty good. There's a mini cog, which is a 3-item memory recall, which is pretty easy. It just takes 3 minutes. And we're looking at different memory categories. Immediate, of course, short term, past few days, semantic memory. We ask about, say, what's the last 3 presidents, and long term, episodic memory. What are some important events going on in somebody's life? Now, attention greatly influences our immediate memory. Confabulation is interesting. Now, we classically think of it in severe liver disease, cirrhosis. How did you get here? Well, I took the bus. And the wife says, dear, you haven't ridden on a bus for 30 years. People who are smart to begin with can confabulate, fill in the blanks, and often their narrative does not hold up. Now, this happens with other toxic states as well. Now, turning to the Gait exam, our Gait exam is, our Gait is very complex. It's amazing we can walk around. 5.5, 6 million years ago, actually the first 7 million years ago, pre-human, walked upright primarily. And these were usually driven by climate change, where we went from the jungle to the savanna. And walking upright gives us a lot of advantages. We can carry kids, we can carry food, we can look for predators, we can hunt better. But there's a lot of trade-offs and problems, from neck and back pain, pain and death with childbirth. We're really the only species that has a lot of pain and death with childbirth. 10 to 15% mortality traditionally. We have all kinds of feet and ankle issues, knee problems, etc. We had to narrow the pelvis so that the baby can get out, so that we can, we narrowed the pelvis so that we can walk upright, but the baby can't get out and the head is too big, and that leads to all the problems. A gorilla can deliver a baby fairly easily without problems, a much wider pelvis. So we look at step length and stride length. Your step length is 1 step, your stride is basically 2 steps. And there's usually 2 phases. There's the stance phase, where both feet are on the ground, most of the time 62%, and then the swing phase, where 1 foot is in the air. All kinds of things have to happen, and the Gait is very interesting. We need everything working right to walk correctly. Our balance, our strength, hip, gluteus, knee muscles, sensation, cerebellum, our frontal cortex. So when we look at Gait, we assess for loss of arm movements. You can ask people to walk across the room. One arm may be not swinging or swinging less, stiffer, and that could be early Parkinson's. Parkinson's usually starts unilaterally. We can have drug effects causing Parkinsonian. Of course, your atypicals and your metoclopramide and a few others. And we want to see if they have a wide base cerebellar dysfunction or normal. We can ask them to walk tandem. If you ask them to walk on their heels and toes, you then don't, in a formal strength exam, have to really assess distal strength in their feet, because you've already done it. They've done it with gravity here. And there's a lot of abnormal gaits. The antalgic, which is due to pain, they're just sort of limping towards that side. It might be hip, it might be back, it might be knee pain, could be ankle pain. Trendelenburg usually is a low back issue. They're usually hunched over their trunk to the side of the pathology, usually a herniated disc. Choreiform, we have our genetic and our acquired choreas. Genetic choreas in childhood often look like an alien. They're all over the place. And then we have our acquired synonyms as number one. We also have genetic more in adolescence or adulthood, which is typically Huntington's, although Huntington's is more of a behavior and dementia problem. We have our dystonic gait. Sometimes it's just dystonia in a kid with walking. Your slappage or your steppage or slapping gait are common because anterior tibialis weakness, because of perineal problems or muscular problems, is common. So they'll have to lift up their foot and slap. It sounds like it's slapping, or steppage, the horse that steppage, those Kentucky walkers. And if they don't do that, they're constantly stubbing their toe because they can't dorsiflex their foot. The ataxic gait, wide base usually. Spastic gait, usually more from, we think of cerebral palsy, MS. The toe walking gait, and usually from childhood. The waddling gait with hip weakness is very common, and you see that. The hemiplegic gait with a true stroke, or you can have functional gait. There's various functional gait disorders. So with functional, you can have functional neurologic disorder where it's subconscious. Previously, we called it conversion, but I don't love that name. It's a little pejorative and misleading. And then you do have malingering gait, which tends to be irregular. Sometimes they'll be shuffling, sometimes they'll be falling to one side, then another side. So if you ask somebody to close their eyes when they're standing and they need to put a foot out to stabilize it, it's usually a central balance issue, sometimes a peripheral neuropathy. On gait, if they need to constantly hold onto a guardrail, it can be central versus peripheral neuropathy.